All right, ready for a deep dive. This time, we're going into the world of platelets.
Those tiny cells that are critical for blood clotting.
Yeah, exactly.
Yeah.
But, what happens when things go wrong?
We're talking primary hemostasis disorders,
Precisely. Those conditions where the initial steps of blood clotting get messed up.
leading to all sorts of bleeding problems.
And that's what we're exploring today.
We'll be looking at things like thrombocytopenias, pseudothrombocytopenia, and even some really interesting inherited disorders.
So first things first, can we just get a quick overview of what normal primary hemostasis looks like?
Sure, so imagine you get a cut.
Ouch.
Right. So immediately, platelets rush to the scene.
Like first responders.
Exactly. And they go through a specific sequence of events: adhesion, activation, aggregation, and then they form that plug to stop the bleeding.
Okay, so they basically stick to the injury site, get activated, call in their buddies, and plug the hole.
Precisely. And von Willebrand factor is absolutely crucial for that initial adhesion step.
Right, I've heard of that. So let's talk about when things go wrong, starting with thrombocytopenia.
Yes, thrombocytopenia. Basically, it means you have a low platelet count.
Okay, so not enough of those first responders.
And there are a few reasons why this might happen. It could be decreased production in the bone marrow, increased destruction, or even sequestration where platelets get trapped in the spleen.
Interesting. So how does thrombocytopenia actually show up? Clinically, I mean.
Well, you might see spontaneous bleeding.
It's out of the blue.
Yeah, in multiple sites, and it's often superficial bleeding. Sometimes, though, the bleeding is delayed, or even a person may have no bleeding history at all.
So it can be really sneaky, huh? So how do we even figure out what's going on?
Routine blood tests, like a CBC, are a good starting point. It'll show us the platelet count and other important factors.
Right. But sometimes a low platelet count isn't what it seems. That's where pseudothrombocytopenia comes in.
Exactly. This is a tricky one because the lab might show a low platelet count, but it's actually a false reading.
A false alarm.
Yeah, due to platelet clumping or satellotosis in the blood sample.
So the platelets are sticking together, making it look like there are fewer of them.
Precisely. And that's why looking at a blood smear under a microscope is crucial to confirm the diagnosis.
Makes sense. Now let's talk about immune thrombocytopenia, or ITP.
ITP, an autoimmune disorder where your body basically attacks its own platelets.
So the immune system goes haywire.
Right. It produces antibodies against the platelets, which then get destroyed prematurely, leading to that low platelet count.
Wow, so it's like friendly fire.
And triggers for ITP can be things like viral infections or other autoimmune conditions.
Okay, so lots of potential culprits. Now, what about heparin-induced thrombocytopenia, or HIT?
HIT. This one is a rare but potentially life-threatening complication of heparin therapy.
Heparin, that's a blood thinner, right?
Exactly. And in HIT, antibodies form against complexes of heparin and platelet factor 4.
Okay, getting a little technical here.
Right, but basically these antibodies cause platelets to activate and clump together.
Which sounds like it would lead to more clotting, not less.
And that's the paradox. HIT can actually cause both bleeding and declotting problems.
So it's a double whammy. Okay, so monitoring platelet counts in patients receiving heparin is super important.
Absolutely. Now let's shift gears a bit and talk about inherited platelet function disorders. We've got a few interesting ones to cover.
Like Bernard-Soulet syndrome, or BSS.
Right, BSS. It's a rare disorder that affects a specific complex on the platelet surface called the GPI-IXV complex.
Okay, what does that complex do?
Well, it's essential for platelets to bind to von Willebrand factor during that initial adhesion step we talked about.
Ah, so without it, the platelets can't grab onto the injured blood vessel effectively.
Exactly. Clinically, BSS typically presents with severe bleeding starting very early in life, often from mucous membranes and the skin.
So we're talking lots of nosebleeds and easy bruising.
Yes. And if you look at a blood smear, you'll see giant platelets. Plus, the bleeding time is prolonged and platelet aggregation studies will be abnormal, especially the response to risankine.
Okay, so giant platelets and problems responding to risankine are red flags for BSS.
Exactly. Now, another inherited disorder we should discuss is Glanzmann thrombasthenia, or GT.
GT, okay. What's going on with that one?
GT is another rare one, but this time it affects a different receptor on the platelet surface called the GPI-IEA receptor.
Okay, and what's this receptor crucial for?
Well, it's all about fibrinogen binding.
Fibrinogen, that's the glue that holds platelets together.
Precisely. So in GT, platelets can't stick together properly, even though there are enough of them.
So it's like they're missing the glue.
Exactly. And clinically, we see mucocutaneous bleeding of varying severity. Lab findings show a normal platelet count and morphology, but absent platelet aggregation in response to most agonists, except, interestingly enough, ristocetin.
So the ristocetin response helps us differentiate between BSS and GT.
Precisely. Now, we've also got other less common inherited platelet function disorders to consider.
Like May-Hagelin anomaly, which also involves those giant platelets.
Right, and then there are disorders affecting the granules inside platelets.
The granules.
Yeah, they're like little storage compartments for clotting factors and other molecules.
So if they're not working right, the whole clotting process can be messed up.
Exactly. And there's also Wiskott-Aldrich syndrome, which affects both the immune system and platelet function.
Wow, so double trouble with that one.
Indeed. Now, speaking of figuring things out, how do we actually test platelet function in the lab?
Right. Let's get into that. I know there are a few different methods.
Well, one commonly used test is the platelet function assay, or PFA 100.
The PFA 100. Okay.
It basically measures how long it takes for blood to flow through a tiny aperture coated with collagen in either epinephrine or ADP. It's kind of like an obstacle course for platelets.
So it mimics a blood vessel injury.
Exactly. And the time it takes for the platelets to plug the hole gives us an idea of how well they're functioning.
So a longer time means something might be off with platelet function.
Precisely. And that's where more specialized tests like platelet aggregation studies come in.
Okay, I've heard of those. You add different agonists to a sample of platelet-rich plasma and watch how the platelets clump up.
Right, and different agonists trigger different platelet activation pathways. So by looking at how the platelets respond, we can pinpoint specific defects.
Got it. So we've got the PFA 100, which is like a screening test, and then platelet aggregation studies to dig deeper. What about flow cytometry?
Flow cytometry is a really powerful tool. It lets us quantify the expression of specific platelet surface receptors.
Like those receptors we were just talking about that are affected in BSS and GT.
Exactly. So it's a very precise way to confirm the diagnosis and figure out how severe the disorder is.
Wow, it's amazing how much we can learn from these tests. But before we dive into specific conditions and case studies, should we take a step back and think about the bigger picture?
Absolutely. One thing that's really important to keep in mind is that medications can significantly affect platelet function.
Oh, right, like aspirin, that's a common one.
Exactly. So getting a good medical history is crucial when interpreting any of these test results.
It's like having all the pieces of the puzzle, but also knowing how they might fit together differently depending on what medications someone is taking.
Precisely. Now, with that foundation in place, shall we explore some of these primary hemostasis disorders in more detail?
Let's do it. Okay, so we've touched on thrombocytopenia, but I think we need to dive a little deeper.
Yeah, it's a fascinating condition, actually, because the presentation can be so varied.
Really? How so?
Well, some people with thrombocytopenia, they don't have any symptoms at all.
So they wouldn't even know they had it?
Exactly. It might be discovered incidentally during routine blood work,
Wow, that's surprising. But for people who do have symptoms, what should they be looking for?
Well, the common signs are things like easy bruising, petechiae.
Those are those tiny red or purple spots on the skin, right?
Right, exactly. And
Yeah.
then, of course, prolonged bleeding from cuts or injuries.
Yeah, that makes sense. Anything else?
Well, sometimes it can be more serious bleeding.
Oh, like what?
Nosebleeds, bleeding gums, even gastrointestinal bleeding.
Okay, that's getting scary.
Yeah, in some cases, there could even be bleeding in the brain.
Yikes. So how do we know how bad the thrombocytopenia is?
Typically, it's based on the platelet count. So anything below 150,000 per microliter is considered low.
Okay,
But the risk of bleeding generally goes up as the count drops further.
makes sense. The lower the count, the less able the blood is to clot.
Exactly. But remember how we talked about pseudo-thrombocytopenia?
Yeah, that was the one where it looks like a low count, but it's actually a lab error.
Right, so it's not a true platelet deficiency.
It's like a false positive.
Exactly, it's a lab artifact.
Well, why does that happen?
Usually it's because of the type of collection tube used for the blood sample.
Okay.
The platelets can clump together or stick to white blood cells.
So it looks like there are fewer platelets than there actually are.
Right, and that's why it's so important to look at the blood smear under a microscope.
A trained eye can spot those clumps.
Right, exactly. It's a crucial double check to make sure we're not misinterpreting the results.
Okay, makes sense. Now let's get back to immune thrombocytopenia, ITP.
Ah, yes, ITP. This one's interesting because it's an autoimmune condition.
So the body's attacking itself.
Right. It produces antibodies against its own platelets.
Like it thinks the platelets are the enemy.
Exactly. And those antibodies, they bind to the platelets, which then get destroyed in the spleen.
Okay, so it's like a case of mistaken identity.
Right, but why the immune system does that, it's not always clear.
Is there anything that triggers it?
Sometimes it's associated with viral infections or other autoimmune disorders. Sometimes certain medications can be the culprit.
So it can be kind of a mystery.
It can be. Now, how does it present? Well, like other types of thrombocytopenia, we often see easy bruising, petechiae, prolonged bleeding.
Right, those are the classics.
But with ITP, the spleen can often be enlarged.
Makes sense if it's working overtime to destroy those platelets.
Exactly. So that can be a clue. Now, how do we confirm the diagnosis? Well, we need to rule out other causes of thrombocytopenia first.
Right, so infections, other autoimmune conditions, medications.
Precisely. And then, if we suspect ITP, there are specialized tests to look for those platelet-bound antibodies.
Okay, so it's a bit of a process, but we can get there.
We can. Now, what about heparin-induced thrombocytopenia, or HIT?
HIT. Didn't we say that one can be really serious?
It is, and it's a complication that can happen when someone's getting heparin therapy.
Which is pretty common, right? Heparin's a blood thinner.
Very common. And what happens in HIT is antibodies form, but they target complexes of heparin and platelet factor 4.
Okay, I'm trying to picture that.
It's a bit complex.
And I'll say.
But basically what happens is these antibodies bind, and it triggers platelet activation.
So they start clumping.
Exactly. And then that leads to, well, a drop in platelet count.
Which is what we see in thrombocytopenia.
Right. But here's the kicker. It also increases the risk of clotting.
So it's a double whammy. Bleeding and clotting at the same time.
Precisely. So you can see why HIT needs to be caught early and managed very carefully.
Absolutely. What are the warning signs?
Well, the key one is a significant drop in platelet count, usually about 5 to 14 days after starting heparin.
Okay, so close monitoring is essential.
Absolutely. And clinically, you might see new or worsening thrombosis, which is blood clot formation.
And those clots can cause all sorts of problems, right?
Right. Things like pulmonary embolism, stroke, even limb ischemia.
So the consequences can be very serious.
They can be. So we have to be vigilant. Now, to confirm the diagnosis of HIT, we have specific lab tests.
Looking for those antibodies against the heparin platelet factor 4 complexes.
Exactly. It's not just about the platelet count. We need to look for those specific antibodies.
Okay, so that's how we piece together the puzzle.
Exactly. And with HIT, time is of the essence. Prompt diagnosis and treatment are absolutely critical.
It's like a race against the clock.
It can be. Now, shifting gears a bit, let's talk about some of those fascinating inherited platelet function disorders.
Okay, sounds good. All right, let's get back to those inherited platelet function disorders. We were talking about Bernard-Soulier syndrome, BSS.
Right, BSS, where those platelets just can't seem to stick to the injured blood vessel wall.
Yeah, because of that defect in the GPI-IXV complex, right?
Exactly. And clinically, that usually translates to pretty severe bleeding starting really early in life.
We're talking lots of nosebleeds, easy bruising, that sort of thing.
Absolutely. And it's often mucocutaneous bleeding, meaning it affects the mucous membranes and skin.
Okay, so what kind of lab findings would tip us off to BSS?
Well, one thing that really stands out is giant platelets.
Giant platelets, like literally bigger than normal platelets.
Yeah, they're oversized, and you can actually see them on a blood smear under a microscope.
Wow, so that would be a pretty clear sign.
It would. And then there's the bleeding time, which is prolonged in BSS.
Makes sense if the platelets aren't doing their job properly.
And then we've got platelet aggregation studies, which show a lack of response to ristocetin.
Okay, that was one of the agonists we talked about earlier, right?
Right, and it's really important for distinguishing BSS from von Willebrand disease.
Ah, because in von Willebrand disease, adding normal plasma corrects the problem, but not in BSS.
Exactly. So those are some of the key things to look for with BSS. Now, what about May-Heglin anomaly?
May-Heglin anomaly, that one also has giant platelets, right?
It does, but there's another unique feature with this one. Dull bodies in the white blood cells.
Dull bodies. Okay, now you're going to have to explain that one.
So dull bodies are these little inclusions you see in neutrophils, which are a type of white blood cell.
And they're specific to May-Heglin anomaly.
Pretty much. We don't see them in other conditions, so it's a really helpful diagnostic marker.
Okay, so giant platelets plus dull bodies equals May-Heglin.
Pretty much. Clinically, you might see mild to moderate bleeding tendencies.
Like easy bruising, nosebleeds, things like that.
Exactly. Now, we also talked about disorders affecting those platelet granules.
Yeah, the granules, those little storage compartments inside the platelets,
Right. And those granules, they're crucial for proper platelet function.
because they hold all sorts of important stuff, like clotting factors.
Exactly. So if the granules are messed up, the platelets can't release those factors properly, and the whole clotting process gets disrupted.
So it's like they're missing some of their essential tools.
Perfect analogy. And there are a bunch of different granule disorders, each with its own quirks.
Can you give us an example?
Sure. One is dense granule deficiency, where the platelets are missing dense granules.
And those are the ones that hold ADP, serotonin, calcium, right?
You got it. And those molecules, they're crucial for platelet activation and aggregation.
So without them, the platelets can't call in the troops and form a proper clot.
Exactly. Clinically, it usually presents with mild to moderate bleeding problems.
Okay, so we've covered BSS, May-Heglin anomaly, granule disorders. What about Glanzmann thrombocythemia, GT?
GT. Now that's a fascinating one. Remember how we talked about the GPI-IUA receptor?
Yeah, the one that's essential for fibrinogen binding?
Right. Well, in GT, that receptor is defective, so the platelets just can't stick together properly.
Even though there are enough of them, they're just missing the glue.
Perfect way to put it. Clinically, we see mucocutaneous bleeding, similar to BSS.
Nosebleeds, bruising, the whole 9 yards.
Exactly. Now, how do we diagnose GT? Well, the platelet aggregation studies are key.
Because they show a lack of response to most agonists, right?
Right, except for ristocetin, which is interesting.
That's how we tell it apart from BSS.
Yeah.
So in GT, the platelets can still clump together in the presence of ristocetin.
They can, but they fail to aggregate when we use other stimuli. And to really confirm the diagnosis, we use flow cytometry.
To look at the expression of that GPI-III receptor.
Right, exactly. It's a very precise way to see what's going on at the molecular level.
Wow, it's amazing how much we can learn from these tests. Okay, before we wrap up, I want to touch on one more condition.
Wiskott-Aldrich syndrome.
Ah, yes, Wiskott-Aldrich syndrome. This one's a bit different because it affects both the immune system and platelet function.
So it's kind of a double whammy. It is. It's a rare X-linked recessive disorder.
Meaning it's more common in males, right?
Exactly. And individuals with the syndrome, they have a combination of immunodeficiency, eczema, and thrombocytopenia with small platelets.
Okay, so they're prone to infections, skin problems, and bleeding.
All three. And it's all because of a mutation in a single gene, the WUS gene.
And that gene is responsible for making a protein that's crucial for both immune cells and platelets.
Precisely. So without that protein, both systems are compromised.
Wow, that's a lot to deal with.
Yeah.
And unfortunately, it sounds like a pretty serious condition.
It is. It can significantly shorten lifespan, but there are treatments that can help manage the symptoms and improve quality of life.
Well, this has been an incredible deep dive into the world of platelets and primary hemostasis disorders.
It really has. We've covered a lot of ground, from the basics of platelet function to some really complex and rare conditions.
And I think it's really highlighted how important these tiny cells are for our health.
Absolutely. Platelets are often overlooked, but they're essential for stopping bleeding and keeping us healthy.
And it's amazing how much we've learned about them, thanks to all these incredible diagnostic tools and research.
It's true. And as research continues, we're only going to learn more and develop better treatments for these disorders.
That's really encouraging. Well, thank you so much for joining us on this deep dive. We hope you found it informative and engaging.
It was my pleasure. Always happy to talk about platelets.
And we hope you'll join us again for another fascinating exploration of the human body.
Yeah.
Until next time.